This lecture is about sexually transmitted infections. Many sexually transmitted infections are asymptomatic, which makes control difficult. Only symptomatic infections are termed sexually transmitted diseases. As with many infections, the clinical presentation does not predict the etiology, and in most settings, laboratory diagnosis is not possible because of costs, distance to the laboratory, and for most infections there are no point of care tests available. So, generally speaking, we rely on empiric treatment, which is referred to as syndromic management. These are the common STI syndromes. There's vaginal discharge, which may or may not have lower abdominal pain, male urethritis, which may have scrotal swelling, genital ulcer disease, swollen inguinal lymph nodes or buboes, Condylomata accuminata, which are genital warts, and pubic lice. To begin with vaginal discharge syndrome, this is abnormal vaginal discharge, and the symptoms result from vaginitis and or cervicitis with or without urethritis. It's important that all women should be examined to confirm the presence of a discharge before therapy is given. The common pathogens causing vaginitis are Trichomonas vaginalis, bacterial vaginosis complex, and Candida species. And those causing cervicitis and urethritis are Neisseria gonorrhea, Chlamydia trachomatis, and Mycoplasma genitalium. The differential diagnosis includes intravaginal genital ulcers, malignancy, and urinary tract infection. The management, once vaginal discharge syndrome is confirmed, depends on the presence or absence of pain on moving the cervix. If this is absent, then in order to cover all the likely causative agents, we use ceftriaxone intramuscularly as a single dose, plus azithromycin as an oral dose, although these can both be omitted if the patient has not been sexually active in the last 3 months. And the third drug is metronidazole 2 grams as a single dose. If there's vulval edema, a curd-like discharge, vulval erythema, or excoriations are present, then you should add clotrimazole to cover Candida infection. Vaginal pessary can be used as a single application, with clotrimazole cream applied 12 hourly until 3 days after symptoms disappear for a maximum of 2 weeks. Patients with lower abdominal pain with or without abnormal vaginal discharge, you need to consider, is the patient sexually active with one or more of the following? That is pregnancy, a missed period, a recent delivery, termination of pregnancy or miscarriage, abdominal guarding or rebound tenderness, vaginal bleeding, an abdominal mass or a fever greater than 38 degrees. If any of those are present, then you should refer immediately to a gynecologist or a surgeon. Lower abdominal tenderness without abnormal discharge, you should consider urinary tract infection as a possible differential diagnosis. Turning now to male urethritis syndrome. This is urethral discharge with or without burning on micturition. Typical pathogens are Neisseria gonorrhea, Chlamydia trachomatis, and Mycoplasma genitalium. The differential diagnosis includes urinary tract infection and intraurethral herpes infection. In terms of treatment, this should be managed with a combination of ceftriaxone as a single dose and azithromycin as a single oral dose. If symptoms persist after 7 days, then you should repeat the ceftriaxone at a higher dose and give a higher dose of azithromycin, plus metronidazole 2 grams as a single dose. If there's no response, consider cephalosporin-resistant gonorrhea. Refer the patient for culture and gentamicin therapy. And if there's treatment failure, you should always consider that there might have been an early reinfection. Turning now to genital ulcer disease, the clinical presentation of which is one or more ulcers, excoriations, or blisters/vesicles on the external genitalia. These can be painful or painless. They may have elevated or excavated margins with or without undermined edges, and there may be swollen inguinal lymph nodes which can develop into buboes, which are swollen lymph nodes with a fluctuant center. The pathogens that cause genital ulcer disease are commonly herpes simplex 2, which is genital herpes, treponema pallidum, which is primary syphilis, chlamydia trachomatis, which is LGV, Haemophilus ducreyi, which is chancroid, and Klebsiella, which is granuloma inguinare. In terms of management, you must always offer an HIV test if the status is uncertain, and ask the patient to abstain from sex until the therapy and symptoms have resolved. The first question is whether they've been sexually active in the last 3 months. If the answer is yes, then you should treat them with benzathine penicillin as a single dose plus acyclovir for herpes. If symptoms persist, then add azithromycin as a single dose, and if they're not improved, they should be up-referred if that's available. If they've not been sexually active in the last 3 months, then they should be treated primarily for herpes with acyclovir. Buboes are a fluctuant mass in the groin and are a complication of some of the genital ulcer diseases. The pathogens are chlamydia trachomatis and LGV, Haemophilus ducreyi, and the differential diagnosis includes an inguinal hernia and a femoral aneurysm. The management is to aspirate when there's sufficient fluid and repeat every 72 hours if needed, and give azithromycin as a single dose. Condylomata accuminata are genital warts. These are warts that occur in the anogenital region, and the pathogen is human papillomavirus. The differential diagnosis includes Condylomata lata, which is a manifestation of secondary syphilis. The management is to offer an HIV test and syphilis serology. If the patient's HIV negative, then you can reassure them that the warts will disappear within 2 years. Otherwise, refer the patients if the warts are greater than 10 millimeters, they're inaccessible, or if they are numerous. Pubic lice is infestation of lice in the pubic anal area and/or eyelashes and eyebrows, and secondary bacterial infections from scratches are common. The pathogen is Thyrus pubis, and the management is to wash all clothes and bed linen in hot water at the same time and to iron them thoroughly afterwards. And in the pubic anal region, use benzyl benzoate, one application for 24 hours, then wash it off and repeat 7 days later. The eyelash and eyebrows can be treated by application of petroleum jelly daily for 7 days. In summary, STIs have non-specific symptoms and signs, and mixed infections occur frequently. There are no point-of-care diagnostic tests available, and so treatment is based on the principles of syndromic management. In terms of laboratory diagnosis, this can be used for treatment failures and for surveillance and research purposes, but is not routinely available.